Thank you for coming. I'm Bob Wells. I'm the Director of the Menzies Centre for Health Policy here at the ANU. The Menzies Centre also has a group at Sydney University, but we host the annual Menzies Health Policy Oration here at the Canberra node here at the ANU. I'd just like to make a couple of acknowledgements. First of all, acknowledge the Menzies Foundation, which is, gives us our core funding and enables us to carry on with, without having to rely on drug company money or other predations like that. So we're grateful for their continuing support. I'd also like to acknowledge the traditional owners of the land on which we're based here and pay my respects to their elders past and present. This evening we're having our annual health policy oration, and I forget how many we've had. I think this is about the fourth we've had. The Menzies Centre for Health Policy has only been running for about 5 years, so we're still relatively young. Tonight's topic is value for money in healthcare, why it's so hard to achieve and what to do about it. So we'll all have the answers in an hour's time. You can all go away and those of you who are involved in policy can fix it for us. Our speaker tonight, we're glad to welcome Steve Lewis, who is visiting us from Canada. Steve is a health policy and research consultant based in Saskatoon and Adjunct Professor of Health Policy at the University of Calgary and Simon Fraser University. Prior to resuming a full-time consulting practice, he headed a health research granting agency and spent 7 years as CEO of the Health Services Utilisation and Research Commission in Saskatchewan. Did I get that right, Steve? He has served on various boards and committees, including the Governing Council of the Canadian Institutes of Health Research, the Saskatchewan Health Quality Council, the Health Council of Canada, and the editorial boards of several journals, including Open Medicine. He writes frequently on topics such as reforming and strengthening Medicare, improving healthcare quality, primary healthcare, regionalisation, and health policy and politics. So welcome, Steve.
Thank you, Bob, and a huge thank you to the Menzies Centre for Health Policy, which has arranged 2 weeks, great weeks for me, of escape from the beginning of the Canadian winter. I know Saskatoon, Saskatchewan won't mean much to you geographically. It's obviously in Canada. We're in the prairie in the western part, north of North Dakota, and it's cold much of the time. So last week I was in Sydney and people were complaining bitterly about the weather, and I thought it was fantastic. It was just, 18 degrees, this is heaven. A little rain, big deal. So it's all a matter of perspective. And it's an honor for me to give the policy oration for the Menzies Centre, and I hope to be able to keep you modestly stimulated in the next 40 minutes or so, and we certainly, as from my point of view, I hope we will have some exchange and dialogue and questions and comments afterwards. So I'm going to try to persuade you in my talk that we don't get particularly good value for money in healthcare. I suspect many of you would agree with that if you're health services researchers or policy analysts. I do think, however, that it's not such a simple thing to get better value for money in healthcare, and in some sense, I will argue that we choose not to get particularly good value for money in healthcare. I'll go over the reasons why. I will then discuss some of the alleged remedies for doing so and what we've tried so far and where we've been modestly successful and where we have a way to go. And I hope to conclude optimistically with some examples of jurisdictions or health systems or subsystems that have done a better job and try to unpack a little bit about why that is so and what the characteristics are. I think there are some similarities between Canada and Australia in this matter. I would say respectfully that both of us do poorly on value for money in healthcare compared to some other countries. We share some characteristics such as, well, we're pink on the map because we're members of the Commonwealth. And we also have the vagaries of federalism to navigate in healthcare, although I would say yours is more creative than ours. It's quite Byzantine and of great interest to observe. So to begin, You'd think that value for money is a pretty straightforward concept, and in some ways it is. So how would you define it? I'm not an economist. I hang around with economists probably too much, so I could give you a little bit of jargon, but I will just put it this way, that value for money is really what are you getting for what you spend? And you can spend in various currencies, all translatable into money or monetizable, as the economists would say. But in healthcare, it's described in a couple of ways. One is just the ratio of your inputs, outputs to your inputs. So an output is an operation, the input is the OR team, the materials, the supplies, the surgical instruments, the lights, the overhead, and so forth. A little more robust definition, I would argue, of value for money is the ratio of the outcomes to the inputs. So if you regard an output as an intermediary or a proxy measure of getting value for money, this is the higher standard. That is, what you're trying to produce is not an operation, you're trying to produce health. So it's the amount of extra health that OR team might produce in a day or in a week. And in comparative terms, because when you say, are you getting good value for money, there are very few absolute metrics of this. We're not hardwired to have a view of what good value for money is or what isn't. It's always relative. So in the healthcare system, you would compare spending on A, let's say acute care, to spending on B, which might be outpatient rehabilitation, or C, community care, or D, mental health for the depressed elderly, and so forth. So when people ask you, are you getting good value for money in your healthcare system, you would have to disaggregate it and talk about, well, over here maybe not, and here's the comparison. So of course the key term in value for money, since we pretty much all understand money, is, although I don't understand some aspects of money, I don't understand why the American dollar is worth more than 5 cents compared to ours given its fiscal situation, but that's another day for another talk. But the key term here is value. And it's not very straightforward in healthcare. It is simply not the case that we expect all healthcare to produce a tangible health outcome benefit. It has many other purposes, and that, I will argue, is one of the reasons why, if we don't get great value for money in technical terms, it's still something that we want to spend money on for other reasons. Clearly not all healthcare is able to produce tangible health status benefits. Lots of healthcare is for to show compassion. It's an attempt to do something where it's difficult to accomplish anything. The condition may be serious, the science, medical science, may not be terribly advanced, and therefore, while we provide care in solidarity with each other, we don't expect it always to yield tangible benefits. Similarly, different groups value different aspects of healthcare. Some people have a fairly hard-nosed view of it. I want healthcare that improves my health status. Others seek reassurance from the healthcare system. So you may want an extra test, or you may want to get a checkup simply because you want to be reassured that nothing may be missed. Different people will have different metrics there. And of course, in some care, some very effective care, the impact plays out over the long term. So if you are in a clinical practice, say a physician, and you have a 62-year-old person with type 2 diabetes, if you do a very good job of managing that person's condition, if you explain to the person why it's important to alter lifestyle and diet, if you minimize the need for medication and you minimize the complications, the tangible benefit of that may be spectacular, but it may be realized 10 or 15 years later. The difference between a well-managed person and one who is less well-managed may play out over a long period of time. So economists would say this creates a value for money calculation dilemma in two ways. First of all, how much of the added health or the precluded adverse event was due to the healthcare intervention as opposed to luck of the draw or the patient, him or herself, taking full responsibility for the condition and therefore not really needing the intervention of the system. And then how much do you value a future benefit compared to a current benefit? And I would say, if someone says to you, what would you rather have? I can give you $10 today or $20 10 years from now. Most people would take $10 today. So the economists call this the discount value of money, or the reduced, the net present value of money declines over time. And all of these things, if you want to calculate, come into play. And finally, we don't know all the time what intervention or whether the intervention did any good. Fortunately, a great majority of human health breakdown consists of self-limiting conditions. So if you have the flu, you go to the doctor, 2 weeks later you don't have the flu, well, you wouldn't have the flu in 2 weeks anyway. So it's not cause and effect, it's a correlation. And so attribution would be difficult there. And extraneous events, external events can come into play. So if I'm mildly depressed, you put me on an antidepressant and I win the lottery and I get better. Did the lottery win improve my status, or the antidepressant, or both? So it's not all that simple in healthcare to connect events to outcomes. Some cases it is. If you have an infection and it's amenable to an antibiotic, that's cause and effect. Immunization, preventing diseases, is pretty much cause and effect. And opening up an artery with a stent and the absence of a heart attack or death a little while later is a predictable causal event. But a lot of healthcare is not. So why don't we achieve maximum value for money? Well, first of all, healthcare itself is estimated to explain about 20% of health status. So when you have a serious healthcare problem and when you get older, healthcare is a more important part of your health. But if you're lucky, if you're not born with a congenital problem, or if you didn't get dealt a bad genetic deck, and if you didn't get hit by a bus or suffer another injury or accident, healthcare is not especially relevant to your life in your first 4 or 5 or 6 or even 7 decades now. Again, if you're fortunate. Clearly, women in their childbearing years will have a greater interaction with the healthcare system and so on. But by and large, healthcare is not a major determinant of your health. So when you spend phenomenal amounts of money on a healthcare system, as both your country and my country do, you wouldn't expect the dial to move very, very much on overall health status or health outcomes, except for a relatively small proportion of the population. Some disorders can be addressed quite cheaply. For example, in the aforementioned example of an antibiotic, penicillin, for an infection. That's pretty cheap, it's pretty instant, and it's great. But if you have schizophrenia or you have multiple chronic diseases, there isn't anything that's really cheap for you. Or if you have certain forms of cancer, or if you have debilitating degenerative diseases, you can spend an awful lot of money for very little benefit. So beta interferon has some modest positive effects for some people with multiple sclerosis. It is unavoidably expensive, and you don't get very much value for money in terms of cost per quality adjusted life year or cost per unit of additional health. That's just inevitable. Science does not progress equally across all sectors at the same pace, and if you're lucky to have a disorder that we have figured out well and is cheaply addressed, then that's great value for money overall. And if you're unlucky enough to have a disorder that is very difficult to address or palliate, let alone cure, and it's very expensive, we will see poor value for money. Ethical norms require us not to be strict utilitarians about healthcare spending. We have the rule of rescue. If someone is lying by the side of the road, you send an ambulance. If somebody has a heart attack, even if they're 85 years old, you're going to take them to the emergency room and you're probably going to do resuscitation. If somebody has end-stage cancer, there is an overwhelming public interest in attempting to prolong life, even when it's very expensive. So this is just the nature of the beast, that we don't have a strict utilitarian calculus across the board. And the conclusion I draw from this is that society doesn't actually aspire to great value for money in healthcare the way we do in some other areas. Healthcare gets a lot more slack in terms of its spending and what it produces for its spending than, say, the education system does, that the social welfare system does, or the public transit system does. That is, I believe, a societal consensus. The question is that consensus manufactured, or is it genuine? Is the public as informed about these things as one might hope? And could you change the public's view of this? And should you change the public's view of this? So, just in case I haven't persuaded you that value for money is a problem, or an issue at least, this graph should persuade you. It's always persuaded me. Its life expectancy at birth is on the vertical axis, and spending per capita on healthcare is on the horizontal axis. Ignore the actual numbers because the data are about a decade old. The dots are countries. So where you want to be on this graph, of course, is northwest. You want to spend the least and get the best outcomes. So if it were otherwise a democracy and a paradise and full of free expression and had a good economy, you'd want to be Cuba on this graph. You might, because Cuba does very well. Cuba's somewhere around here. If you want to waste a lot of money and get poor health outcomes, then move to the United States. And if you want to be like us, you'd stay in here. This is our cluster, Australia's and Canada. So we've gone a long way along the flat of the curve. We spend, again, ignoring the actual numbers, we spend 3 or 4 times as much as you would need to maintain the life expectancy and infant mortality rates that we observe in Canada and Australia. So the question is, it's not that we get nothing for spending the extra money, but what are we getting? What are we expecting? And have we had a good and serious conversation about how far along the flat of the curve we want to go? And I would argue we're just starting that conversation in Canada. The Health Council of Canada did produce a value for money report that just opened up the conversation, discussed some of the concepts, but it's not spreading like wildfire and people aren't marching in the streets to move leftward on the curve here. Well, let's start to get at some of the reasons why value for money is all over the place. This is an oversimplification, but there are 2 groups involved in healthcare transactions, the people who receive it and the people who provide it. And for the people who provide it, all healthcare expenditures is somebody's income. So if you're the public here, that our utility curve looks like this. So as the costs go up, the marginal benefit drops off. For the first bunch of healthcare spending really delivers fantastic value for the money. That's when the spending on, again, the public health measures, on some interventions that are known to be terrifically effective, on certain kinds of highly effective drugs, certain kinds of pain killers and pain relievers and so on. It's really effective, but then it drops off and it flattens off. It's the same, in other words, as the country curve. That for the overall public, the population at large, as the marginal costs increase, the marginal benefits flatten out. But for providers, they don't. The more we spend, the more money goes into providers' pockets. And unless the providers are, in my country, cataractologists, who probably have a flattening out of their curve too because they make so much money. For everybody else, it's pretty linear. Think of our own middle-class income curves. Your next $10,000 is going to deliver pretty good value, and you're going to value that quite a bit. So when you have these 2 conflicting curves and a whole lot of healthcare decisions are essentially driven by the supply side, you're going to have a recipe where, for a fairly relaxed view of value for money, because it's not just the public generating independent demand. In fact, I would argue that we rarely generate much independent demand in the healthcare system. Our cues are taken from the supply side. So if I have at least partially persuaded you that value for money is worth discussing, how do we get better? Well, we need to decide what better means. And again, we have to unpack the concept a little bit. So one thing that defines better value for money is that we're more efficient. We get more units of output, not necessarily outcomes, for the units of input. And a great example of this is multi-channel lab testing. You can get 20 lab tests with a single pass now. So it's incredibly efficient. The cost per unit has gone down. So in technical terms, it's a value for money improvement. If it used to take 5 minutes of a lab tech's time and a couple of minutes of processing time to get a lab result, if for the same amount of time, in both cases, we can get 20 lab results, you could argue this is a spectacular improvement in efficiency. Whether or not all those extraneous results you get by doing 20 that cause the clinician to scratch his head and worry is value for money in a more substantive sense is a different question. Healthcare can also get more effective, and indeed it has in many areas, better outcomes per unit of input. And a good example is CABG, cardiac bypass grafts. So coronary arterial bypass grafts. It used to be the case that it was dangerous to do heart surgery of this sort on the elderly. But in the last few years, it has become safe to do CABG operations on people over 80, and it's very good outcomes, and it's not terribly risky anymore. So that's an improvement in effectiveness that would urge you to spend more money at the margins, and we do. Another better value proposition is access. People value not having to wait, and people value getting care closer to home. So probably the most spectacular improvement in value for money on the access variable in recent history has been the UK, which in a 10-year period went from very, very long wait times for elective procedures, often 2 years or more, to the elimination of long waits for all procedures. Nobody waits more than 4 months from the time of GP referral to having the procedure unless there is a medical reason for delay. And in primary health care, 99% of people in England, if they call for an appointment with the physician or the primary care clinic on Monday morning, will be seen by Tuesday afternoon, which is infinitely better than my country does, and I can tell you personally, a lot better than my own clinic does, where it would take 3 weeks to get to see my GP. And finally, though this is a rarity in healthcare, it can get cheaper. And the main thing that gets cheaper in healthcare is drugs that go off patent. So the price will drop when generic manufacturers take place. A great example of this is statins for cholesterol lowering. Most of the time, healthcare pricing is very sticky downwards, as they say in the economics world, which means in plain language, the cost always goes up. It's not like computers. If it looks like CT scanners are getting to be cheaper, then they develop a new generation of CT scanners to keep the price up, and we pay. So how have we done in achieving all of those benefits? Well, as I mentioned, we have achieved some technical efficiency gains. So cataracts is a great example. It used to be, many years ago, an inpatient operation that was quite complicated. Now it's 12 minutes day procedure. Interestingly enough, the fee that accrues to the ophthalmologist hasn't gone down commensurate with the simplicity of the operation and the reduced complexity, but that's another matter. It's still much, much more efficient than it used to be. And we have a lot more non-invasive diagnostics. There isn't much exploratory surgery anymore. Used to be routine. So this is not only much better for the patient, of course, not to be opened up, closed up, and endure an inpatient stay, but it's also cheaper. We have modestly improved effectiveness in some areas, despite the war on cancer launched in the 60s by the United States and the enormous amount of money we spent on cancer research and trying to develop new cancer drugs. Across the board, the results are kind of discouraging. I think you'd say this was a very unfortunate value for money proposition. In some areas, children's cancers and so on, we have done quite a bit better, and we should celebrate those triumphs. There is the occasional blockbuster drug that comes onto the market. Again, I think used appropriately, statins have been a great virtue. We have pain control medications that are better than they used to be. We have cancer drugs with fewer side effects than we used to have. And then we have other drugs that were touted as blockbusters and turned out not to be, Vioxx being a good example. We've had some major accessibility triumphs. I mentioned the UK. Some practices in both of our countries have done a better job of scheduling, reducing wait times. The implementation of telehealth has made care more convenient for people in rural and remote areas and so on. And again, occasionally we get a better price break, and sometimes governments bargain hard and actually negotiate across the board a better price, and that is certainly a value for money advance. However, on balance, I would argue we haven't done very well. And for every little triumph, one step forward, we take a step back, and sometimes two. So whenever you become more efficient at something, you tend to crank up the volumes. So even if we're more efficient at providing CT scans, MRIs, and cataracts, the response is to lower the threshold for intervention and expand the indications. So you can be very, very efficient at producing marginal cases, marginal units of interventions or testing or whatever that don't yield much benefit. So you can be very efficient at things that don't need to be done. And overall, I would argue that's a poor value for money proposition. We relax the appropriateness criteria if we have them at all. So if Canada and Australia are both on the anarchy end of clinical decision making, that is, practitioners have a lot of autonomy, there's not much practice profiling, there's not much of an attempt to rein in variations in practice, you can lower the threshold for an intervention, for a diagnostic test with pretty much impunity, and as the system gets more technically efficient, you can just do more, which washes out any true value for money improvement. Knee arthroscopy is a classic example. It's brilliant technology to be able to scope a knee, but the randomized controlled trials are pretty clear that most of it is completely useless, no better than placebos. So again, being very good, very efficient, and very high-tech and glamorous for something that most of the time you don't need to do. And I think this third bullet is actually probably, if I were to summarize, why don't we get very good value for money in healthcare? It's because we, the people, have been persuaded that a pharmaceutical paradigm to health improvement is probably the way of the future. We are enamored of healthcare technology just as much as we are by technology in every other sector. You know, the computer era, the graphics, the DVDs, the Wiis, all of the technologization of modern life, and healthcare is a subset of that. And the entry price of new technologies, which I think has been a colossal failure in healthcare, has nothing to do with its benefit. It has everything to do with the reported cost of production, building in a high profit margin. So the system tends to be what the economists call a price taker. You want to sell me a new product, I'm going to pay what you ask, and I'm not going to discipline my purchasing very much by how much benefit I expect. And this is a recipe for poor value for money as well. Another issue when we try to get a handle on this is that there's no consensus on what you would spend the money on elsewhere if you didn't spend it on healthcare. So we know it's pretty well, in my view, established that if we took money out of healthcare and reallocated it to some other social areas of social and economic spending, overall health status would improve. Read Wilkinson and Pickett's great book called The Spirit Level, and you have a ton of data that show that more egalitarian societies, other things being equal, are healthier than societies just as rich but with a wider disparity in socioeconomic status. But of course, when you do those reallocations, you're reallocating away primarily from the middle class, but of course from the upper classes as well. And the consequences are different. A reallocation that produces more overall health will improve the health status of lesser advantaged groups. The consequences will be perhaps some less access to health care for the middle class, and they are not going to benefit from reallocations that are to improve the non-medical determinants of health because theirs are fine already. By definition, they're middle and upper middle class. They've got good housing, good clothing, good food, access to education, so they don't need social spending. In fact, they're the ones who subsidize social spending. So that's why it is a difficult political proposition to engineer a reallocation that would absolutely improve overall health status and certainly reduce disparities between the middle class and the lower quintile or so on the socioeconomic gradient. So if you want to say on a strict value for money calculation, the purpose of healthcare is to maximize population health status. Maximizing population health status is a direct benefit for disadvantaged people and a vicarious benefit for middle class people because we don't know how to maximize, we don't know how to produce much more health status for middle class people. It's just not possible scientifically to say we know with more spending we could improve the health status of the middle and the upper middle class. And to put it differently, if you want to perceive this as a competition for resources and the degree of tolerance that the advantaged have to subsidize the well-being of the disadvantaged, there ain't nothing in it for the advantaged classes in terms of direct self-interest. And they may actually perceive that the opportunity cost, what you give up from inefficiently and ineffectively spending healthcare dollars is pretty low. In other words, they might say, yeah, we know we waste a lot of money on healthcare, but at least it's something we use. And we don't mind because we don't actually know in aggregate how we would spend the money differently and get better well-being. I don't actually think that's true. I think parents who have kids sending their kids to schools and universities notice that tuition rates tend to be higher these days, partly because healthcare spending is consuming more and more government revenues, and you have to shortchange other sectors in order to keep sustaining the increases and so on. But nevertheless, I think that's the case. And finally, you know, it's not them and us again. Remember that the middle class, the upper middle class, a huge chunk of those constituencies are also healthcare providers who do benefit directly from increased health spending. And it's not just the people directly employed, doctors and nurses and therapists, it's also the manufacturers, the vendors, and so on. So it's a big chunk of the economy. Yet another factor why it's so hard to achieve good value for money is that we don't know who's accountable for it. People are very good at pointing fingers in multiple directions for who's the culprit, if they indeed see that there's a culprit. This is the most complex human system ever invented in any sector. Modern healthcare systems are immensely complicated, and while we say they're managed and governed and organized in certain ways. They are certainly not organized and governed and managed in the same way that Telstra is, or that a pharmaceutical company is, or an auto manufacturer is. It's much more diffuse. And when you have professionals delivering care, they do not perceive themselves as having organizational loyalties and a chain of command in the same way that others do in other sectors. That's just a description. I'm not judging it one way or another. So we have physicians who drive approximately 2/3 of all healthcare spending as the gatekeepers. They, by and large, are not particularly anxious to embrace a stewardship role over resources. They don't want to be in charge of a pot of money and have to make allocative decisions. And to some extent, I think that's perfectly reasonable, because we want physicians mainly to be focused on their patients. But since they have no interest in it in my country, but are very happy to drive the costs, you end up with an adversarial relationship of supposedly the bean counters and the bureaucrats, as the terms are used, holding the purse strings and denying people care, while you have the altruistic medical profession and its allies just wishing to secure access to resources for the population in desperate need of them. So you have an unconstructive conversation about this, and it ends up that the public, by and large, will believe healthcare providers more than they will believe what governments say about healthcare spending. So the ultimate political conclusion is spend more, and we do, and we have. So what haven't we solved? I think we haven't solved, and I will acknowledge right off that this is a statement and a contention that should engender some dispute. I think clinical autonomy is, in theory, a good thing, but if it is uncoupled to any sense of accountability, either for quality or for resource utilization, it's a bad thing. And I think in Canada, I would also argue in Australia, we have pretty much unfettered clinical autonomy and not very much attention to other forms of accountability, and it's part of the value for money problem. We also have a very active and successful supply side that drives utilization. I think it's a myth to say that the public itself is generating all of these additional expenditures because we're so demanding. Again, I think our demands and our expectations are mainly mediated by the supply side. We don't have a sense of stewardship. And in Canada, at least, we have a very diverse and incoherent view of productivity. Governments, on the one hand, want to get physicians off fee-for-service, for example. And yet when physicians go off fee-for-service, governments say, you better dummy bill using fee-for-service principles and criteria so we can make sure you're still being productive. Well, you can't have it both ways. If you don't want a volume-based system and you don't want to pay for volumes, don't then hold people accountable for producing the same volumes they did in the system that you wanted them to abandon. So we're not very consistent on that. Perhaps you're a little more than we are. The public doesn't get it, frankly. The public has no clue that quality is a bigger problem than access, and that there is a superabundance of care in some areas, notably polypharmacy among the elderly, and in some cases exposure to radiation in CT scanning that actually does more harm than good. The public is much more fixated on, I want to be seen immediately when I need to be seen, and if I worry about having to travel too far, I want you to spend more money. So, not to leave you on a pessimistic note, what can be done to improve value for money? Well, I think there are a number of things, and a number of them have been tried, a number of them are partially implemented, and there have been some notable successes in both of our countries, I believe. I don't think we have an evidence-based health system, but it's better than it used to be. And I think in some areas, like the drug formulary committees and so on, they do a pretty good job of looking at the evidence and trying to recommend decisions that are based on a value for money calculation with appropriate flexibility to account for very difficult conditions where you need to spend a lot of money to make a little progress. The unfortunate downside is that often the evidence-based decisions of formularies are overturned to the political level in response to interest groups and lobbying and pressures from both manufacturers and patient advocacy groups. Sometimes you get governments that are really gutsy. New Zealand is ruthless the way it bargains with drug manufacturers, and particularly generic drug manufacturers. It's a small country, and you wouldn't think it would have such clout, but they have a lot of guts. And as a result, until recently, generic drugs were 4 times more expensive in Canada than in New Zealand. So we applaud New Zealand, and probably as a result of the New Zealand example as well as some others, the province of Ontario just legislated a 50% reduction in generic drug prices in that province, which of course occasioned a hysterical response from pharma manufacturers and the pharmacists who were getting rebates of $100,000 apiece on average from the generic manufacturers, all licensed and regulated kickbacks by the government, by the way. The most bizarre scheme you ever saw in your life. But on occasion, you get a public policy triumph that gets better value for money for all. There are prospective payment systems, so paying for the complexity and severity of a case instead of global budgets for hospitals, I think, was a value for money improvement. We are re-engineering some aspects of healthcare. My own province has embraced what is called the lean production method in healthcare. It's adapted from Toyota. It's essentially a series of processes where you look for the waste in the system, and you do it by simple, incremental little steps. So for example, in nursing, you will reorganize the supply cupboard so you spend 1 minute less every time you look for a supply or a drug in your supply cupboard. You will move certain pieces of equipment closer to the center of the action to save several hundred steps a day for orderlies and nurses' assistants and so on. And over time, you get rather remarkable gains in productivity without adding new staff, and you have more direct care for patients. Pay for performance is the fad du jour around the world. If you know exactly what you want to pay for, and if you can eliminate the unintended consequences of setting the bar too low, and in paying for things that you can count rather than the things that are complicated that you can't count so easily, P for pay makes some sense. I don't think it's actually worked out very well, and I think it's enriched a lot of people for very modest performance, but nevertheless, on occasion, it does what you want it to do. But again, my conclusion is, though there have been some successes on some fronts, and perhaps all of these fronts, but the results are not revolutionary, and hence the cost curve is by no means bending downward. And just to give you an example of how tricky value for money is and what to do about it, this is anti-cholesterol consumption in populations. And you're the last one here. Australia, for some reason, is just gone nuts for statins. You people are consuming statins at a rate that I would have thought unimaginable. There's almost a conscription of people to take these at these rates. And then look at the variations. You know, I mean, you're almost double the OECD average. And Canada isn't on this because our data aren't good enough, so congratulations that Australia can actually count this. And then you see Germany, which has a quarter of the statin consumption rate as Australia. So who's right? Well, it's not entirely clear, because this is the coronary revascularization rate, and look where Germany is. If Germany, one could say, if they had taken more statins, they wouldn't have had to crack open so many chests. So maybe you're doing okay because you're in the middle here, and maybe you prevented a lot. So when you get into the nitty-gritty of this, we need to have conversations about things we've never had conversations about, such as, what is the right rate in a population? You can comb the worldwide literature, and nobody will say you should have 122 anti-cholesterol scripts per 1,000 people per year, because that's the optimal health status impact. And beyond that, it drops off very steeply, and below that you are not avoiding harms you could avoid. You never see any discussion of this, so you don't know how much to do of these things, and hence you get massive variations in practice. Within countries, the variations are enormous. Usually 2 to 3 to 1 is very common. And if you don't know the right rate, and if people aren't up for a conversation about the right rate and where to set appropriateness thresholds, it's very hard to make large-scale improvements in value for money. And finally, just a couple of concluding observations. Value for money is, of course, about the total amount of money you spend and per capita spending and those aggregate measures, but it's not just how much, but where. Allocation really matters. I would argue that if you take a system like yours or ours, if you didn't decide to spend less money, but you hived off spending in the drug and diagnostic imaging and some other areas that I don't believe delivers value, and invested heavily in comprehensive primary health care, some targeted multi-sectoral interventions among the really disadvantaged and the Aboriginal populations, you would get better value for money without spending less money. I would also argue that if your new spending concentrated in certain high-value areas, you would have an overall improvement in value for money, even though you're spending more money overall in total. So it's not necessarily the size of the pie, it's the composition of that pie, where the slices are divided and who gets the money that matters. And of course, this is a function of all of these things: interest groups, historical patterns, beliefs, and power. And unfortunately, I would argue, The money and the way the health system is organized is geared towards the needs of the politically dominant classes, and those are the middle class and above. And it's not just that the healthcare system spending is disproportionate there, which means our needs get more attention per unit of need than the disadvantaged groups do, even when the disadvantaged groups use more healthcare dollars than we do because their needs are so much higher. But the system is organized perfectly well for people who need episodic care and a bit of high-end diagnostics and some lifestyle-enhancing surgery once in a while. It's terribly organized for the people who have multiple chronic diseases, the frail elderly, and the poor. So value for money in an aggregate sense really suffers because the worst value for money, I would argue, accrues in those areas where we most need a more organized, better organized healthcare system. So who does well? A few examples. Kaiser Permanente in the United States is a wonderful system combination of cost and quality. It's not much more expensive than the NHS, which is amazing since it's in the United States. And it has terrific outcomes, terrific access to specialists, longer primary care visits, more procedures are done. The big difference, they use way fewer hospital days than England. So you can save a ton of money and spend a whole lot of money upstream if you keep people out of the hospital. And that's the first way to get better value for money. Veterans healthcare in the States, many of you know the story. It was the basket case of American healthcare in the early 90s. 4 years later, it was among the best. And look what they did. They closed 55% of hospital beds, opened up 300 new ambulatory care clinics, and made a major effort to improve screening for certain conditions. This is a spectacular transformation in a few years, on the likes of which we can't possibly do in Canada, and I suspect you would have difficulty doing in Australia too. But it just shows you it can be done with enough will and with enough pressure. And I won't tell you much about this one, but Jönköping County, Sweden may be the world's most cost-effective and quality-oriented healthcare system. It's only 350,000 people, but it is far and away among Sweden's 21 counties the leading performer on both quality, access, and outcomes. So what do these great systems have in common? Well, one thing they have, and you don't have it and we don't have it, is active clinical governance. That is that medical care is something that you need to manage like every other human enterprise, and you manage it by reducing variations in practice, having an emphasis on quality, and helping people to continuously improve. They do emphasize the upstream end of the system more. I don't want to be glib about this because we don't actually know how to do health promotion fantastically well with a big health impact, but at least they try harder and they spend more on it. I mentioned hospital avoidance before. Leadership is really important, which is trite but true. I think those systems that have gotten off thinking that you can tweak people's behaviors by handing out financial carrots and penalties have done better when they talk about it as a cultural transformation, not a financial incentive calculation. I think that's a very important point, and I would argue that trying to change cultures is more effective. And finally, they have great health information systems in real time, so you can actually measure what you're doing, calculate its benefits, and try to do something about it. So to conclude, what would you do to improve value for money? Well, these are some of the things that I think would work. You need to decouple funding and payment from volumes. Don't define productivity in terms of doing more, otherwise you'll do more. And in advanced countries, I would argue doing more is exactly the wrong thing. We should actually probably do less, and certainly do less for some groups, more for others. I think we need to have a conversation about appropriateness. It is a very touchy proposition, but we have to have it. Some things are not appropriate. You have to draw a line somewhere. In my country, there was a famous study that showed that 26% of people who had cataract surgery were worse off visually after the fact, and nothing changed as a result. Well, that's disheartening, and those are the kinds of things that need to lead to real change. I think we need to talk about what the appropriate rate of intervention is. I think we need to integrate budgets so that money can flow to where the need is, and more importantly, to the most cost-effective place of need. In my country, there are incentives to keep people in high-cost care venues because of the way the system is organized and how public coverage works. That's perverse, it's needlessly expensive, and it doesn't produce anything of value, and so forth. I think on the vendor side, we need to signal to the drug industry and others that, give you a bit of a respite period, but in a few years' time, we are no longer paying the entry price of drugs unrelated to their therapeutic benefit. And we're sorry if you invest hundreds of millions of dollars and don't get a drug that does much for us. We're not paying you back for that one. It's just not going to happen that way anymore. I think it would alter the research agenda, much less emphasis on Me Too's, and a lot more creativity in developing drugs for the disorders that are neglected now. Primary care is the fulcrum for all of this. If we get that right, we have a chance. If we don't, we won't. I think we need to do a lot more public reporting on things like value for money, because the public basically has no clue about what kind of value for money it's getting for its tax dollars and its insurance premiums and its out-of-pocket spending. And I don't think it's a bad thing to invite the auditors general into the pie, although health people get very nervous, but they do have a value for money perspective, and applying some of that scrutiny, I think, is important. So I will stop there. Thank you very much for your attention. Very happy to take your comments, questions, and feel free to argue with some of these propositions, because I realize they are not all self-evident. So over to you. Sure.
Thank you very much for that, and I think there's plenty of food there for questions. We welcome questions, comments. Just to explain, Jason here has this event is being vodcast and will be available somewhere on the ANU website sometime soon.
On ANU channel.
ANU channel, it's called. So you go to anu.edu.au and type in ANU channel. But not tomorrow, but sometime soon. So Jason will be manipulating the microphone to pick up everybody's questions. So you know that this is a public event. Could you please, we'd be grateful if you could identify yourself and any institutional affiliation you might care to mention when you ask your question. But you can stay and you remain where you are. The acoustics here are pretty good, but please try and speak up as much as you can. All right, Jason? Right. Yeah. Okay. So over to you. Questions, please.
John Goss, health economist, University of Canberra. I agree with much of what you said at the end about how we could improve the efficiency and effectiveness of the health system. But I thought you were rather pessimistic in your early part in saying that the health system had been unsuccessful, because I think if you look back on the last 30 or 40 years that we have in fact got extremely good value for money. I mean, if we take the cardiovascular disease area, for example, we've had an 80% reduction in age-standardised mortality rates in the last 40 years. Now that of course is due to a combination of public health interventions, better treatment and social determinants of health. But there is no question that the health system has been a major contributor to that 80% decline in cardiovascular disease, death rates. And there are other areas. I mean, you were pessimistic about cancer. We have had very good improvements in cancer survival rates, and the United Kingdom is the classic example where they were not spending enough, and so they had 30% 5-year cancer survival rates, whereas in Australia we had 50%. We have 50% 5-year survival rates. So the money we spend does actually make a big difference to the health of the Australian population.
So let me I won't say I disagree with you, but I would say that the jury is out on both counts. And we can go at this a little bit. I would say that the biggest, the decline in cardiovascular disease, and if there are epidemiologists in the room, please feel free to weigh in. There is an inexplicable decline in cardiovascular disease and in stroke incidence in the last 30 or 40 years that it's a bit of a black box for the explanation, but most people, it is true that surgical outcomes are better and we can do more surgeries, but on a population level, this is an epidemiological phenomenon, not an intervention phenomenon. And on cancer, as you know, there are enormous debates about what is causing the ostensible decline in death rates. A lot of people are still concerned about lead time bias, that we are detecting more than we did before, and therefore ostensibly curing and prolonging life that we hadn't detected before. So I'm a little less sanguine than you about this, but I will not disagree that both the technical efficiency and in some areas the health outcomes due to interventions per se, not the socioeconomic determinants and so on, have been better. The question is, at what cost? And if your metric is narrow, and if you're looking group by group, I think, sure, you can find some both technical efficiencies and better outcomes. But if you're looking in aggregate, and here I would broaden it to the Northern European social democracies, which are really, really concerned about reducing disparities in health status. They've been unsuccessful even though they have stronger social safety nets and everything else. So I think the healthcare system is powerless to move the curve to the right on overall population health status, even if it does well for certain groups of people. And the question is, how much more money do you want to spend to improve the life expectancy and the outcomes of a relatively small number of people? I don't suggest I have the answer, but I think that's the curve that I think is perplexing a lot of people.
But we are moving the curve to the right because life expectancy continues to go up substantially.
But it does, but it's a secular trend that has nothing to do with healthcare. That's the dilemma.
I'm sure 90% of epidemiologists would disagree.
I don't think so. I think the R squared of the healthcare system, there's a pretty good consensus that it's somewhere from 20 to 30%, no more on that one. So maybe they will. I mean, sure, it's a debate for sure. I agree.
My name is Andrew Mackay. I'm an agriculturalist, and when I employ a vet, the first thing he says is, "What have you fed the animal?" And fed the animal. And I could just make 2 points. In the First and Second World Wars, the milk production collapsed in the UK. The population's health improved because they had the national loaf. And the national loaf was the whole grain. And the reason the milk production collapsed is that the wheat germ, all the things that don't go into white bread, were fed to the cattle. So the cattle were doing very well and the population not doing well. So the wheat improved, the bread improved, probably less sugar, so that they improved their diets and they were more healthy. And when you look at selenium, you mentioned cancer. Now Braidwood, I come from, is has low cancer, a low selenium level. And now you'll find in all the stock and station agents, selenium supplements for stock. Now in Australia, it used to be, I discovered that 30 years ago. And 30 years ago, you had to get a prescription to get selenium. Just recently, it's been lifted from, I think, 25 mcgs to 125, 150 mcgs. Now, when you say cancer has been disappointing, there's research which was published in 1996 with 50 to 60% reduction in some cancers with a selenium intake of 200 mcgs. No other results have ever been as good as that, as I understand. So my point to everybody here is it's what you eat and it's what the answer lies in the soil. Because our soil has been degraded. There's too much phosphorus in it. We've put too much phosphorus in. We have incredibly low levels of selenium, which leads to depression and suicide. And magnesium is not good. That is where the real, I think, benefits are going to happen if we can get that sorted out.
Well, I'm not competent to address the scientific area, but I will say it suggests the iron law of healthcare, which is never pursue a simple solution when a more complicated and expensive one is available.
You're quite right. Yes, that's a big part. Thank you, sir. Up the back.
Yes. My name is Marion Riley. I'm with a member of the Healthcare Consumers Association of the ACT. And I'd like to suggest that my members are very interested in quality and safety of health services. I mean, they don't just work on the basis of accessibility or resolve all problems. In fact, consumers of health services are very interested in a broad spectrum of health services. Cost is obviously one factor, and I don't think you can just dismiss and say the public is not interested. I think the public is interested, and I think now with the changes of information availability in terms of the number of websites around, and I'm talking about quality websites, not the rubbish ones, that people actually know a lot more and are expecting a lot more from the health systems. And I don't think that's more money spent on them necessarily. I don't think it means services to the nth degree. I think it's actually finding some resolution and improving quality of life. And I think these things also have to be taken into account in relation to the delivery of health services.
Well, thank you for that. And I think, so to say, first of all, I think you're in the vanguard. I hate to tell you this, but I think your view is advanced. In my country, while we have published reports about quality and safety, there's a huge emphasis in the policy world and in quality councils and in some institutions to improve it. The public doesn't get much upset by the publication and the availability of some horrifying quality and safety data, but it will march in the streets about access. And if you propose to close 20 beds in a hospital, or you propose not, if there's a 3-month lineup for a CT scan, it exercises its might and its voice, and it translates into political promises and resource allocation of the sort. So come to my country and help lead that conversation, because we are quite discouraged. And I don't mean to be universal about it. Of course there are. There are some very good public and citizens groups that are onto this. You're right, the information is more readily available, but it's not translating into very much policy and resource allocation in the directions you would like. So keep it up.
Yes.
My name is Alison Ballard from the Australian College of Ambulance Professionals and the Ambulance Service of New South Wales, and also a student at the University of Canberra. Have you given much thought to the role of emergency medical services, as in ambulance, in providing or improving value for money in healthcare?
Well, I mean, clearly emergency services are essential. There are lots of debates about the distribution. We have found in Canada, we have increasingly sophisticated paramedics who are able to deliver a lot more early stage interventions right in transport and so on. So that's all good, and it's actually contributed to some better outcomes. And it's one of those things where emergency services and rescue, this is something where you don't have a whole lot of debates, and nor should you. I mean, this is a basic entitlement in any healthcare system. The big issue is how extensively you can distribute services in rural and remote areas. I mean, you obviously have vast empty spaces in Australia, so do we in Canada. And when do you do air? You know, can you afford helicopters? What percentage of, what would you spend to increase the safety and accessibility for a very few people in remote areas? It's an obvious calculation, right? And it's sometimes, there's no win there. But I don't know in relative terms if you made the calculations. So is the emergency service system relatively cost effective? I would argue yes, it's quite cost effective. Where it gets murky in Canada is that it used a whole lot for routine transport, and is that a good use of it, and so on. And of course there's the other dilemma of there is some unavoidable inefficiency in an economic sense where you have people, of course, on standby waiting, and there's not a lot of other work to do. So what do you do? But that's why you can't get perfect. I mean, there is no wonderful, completely cost-effective way to do all of this outside of urban areas and even within urban areas, I would argue.
Well, first of all, they're not run straight out of departments of health.
Well, the VHA is.
Well, is it? Or
Oh,
is it more arm's length than that? I mean, is it subject to the whims of changes in government from day to day, etc., etc.? Or is there's another story there about arm's length administration? I think about some of the success stories in our country, like Cancer Care Ontario, right? It's actually a bit away from government. I mean, it's not that they're completely immune from political wills. I think about Pharmac in New Zealand. It's actually got a bit of immunity from the political winds of change. In Canada, as we know, that most you have deputy ministers are around for a long time if they're there for 2 years. So it's hard to get any kind of movement along the line. So I just wonder what your think maybe the story isn't about arm's length administration, but what is it about those organisations that makes them different, and how could we look to those characteristics rather than what they do? Because what they do is clearly good, but...
Yeah, well, I do think it's a complicated question, and I'll try to give you a fairly simple answer. I don't think governments directly running anything in the healthcare system I wouldn't recommend it. However, Veterans Affairs is an interesting example. It's probably the world's most socialized health system. It's amazing. It is directly run by the government. The government owns the facilities. The government employs the people. They're federal civil servants, which is so anathema to the American political culture. And then Americans actually, including right-wing Republicans, say, oh, the VHA is fantastic. But they don't generalize it. I don't think that there is any proven method of how you would govern a healthcare system. But I think the active ingredient in the ones that work is management. So you don't have, in the Kaiser Permanente system, a right to get a contract to be a service provider there. They can kick you out. You sign a contract. The contract has provisions about performance. They profile your practice, and if your practice is an outlier, they either help you to get better, or if you persist in poor outcomes, profligate use of resources, unhappy customers, patients, whatever, they can kick you out. I mean, I don't recommend this is a great thing to do. I mean, I don't want people to be vulnerable, and I think job security is good, and I don't want people looking over their shoulders. But there is a discipline involved in those systems that we don't have in Canada. In Canada, you have a right as a practicing physician to a billing number, and you can practice wherever you want. If my city is saturated with doctors and the rural area has none, all the new graduates can practice in my city, get a billing number, generate some demand, and bill the government. So it's ripe for poor value for money on that sense, and it neglects a lot of people. The other thing that they do is I think they take health information much more seriously than we do. They measure what they do, they measure the performance, and they generally try to act on it in order to get better, and they take quality improvement safely. But I guess in a nutshell, they are not open-ended systems that take all comers. They are circumscribed, they are closed-ended, and the very fact of management of how services are delivered, how resources are used, and the outcomes they get, I think is a cultural feature that we don't have. We have a very autonomous practice culture in Canada, and we don't manage much of that at all. So I don't know, do you think that's plausible? I could have told you that in Canada. You didn't have to come all the way down here, but I'm glad you did.
One last question for Lorraine.
I have a related question. Lynette Glendinning, Chair of the Menzies Centre. Do you see, Steve, when you look at those graphs across not only the Western world but the developing world, do you see any signs that over the next 10 years that either the ageing population, the cost of health care, or the capacity of the community to discuss health, which, as you say, is an extraordinarily complex system and so few people really even understand the system. Do you see any signs that we're going to get more sophisticated or better as communities in being able to actually have the conversations about the de facto rationing that's occurring, the kind of trade-offs and questions, whether you call it value for money, because that's not the discourse. It's certainly not the discourse here. It's a very simplistic discourse about elective waiting surgery times, numbers of doctors. What would you see as the things that might trigger any improvement in that kind of community's capacity to have this conversation?
A couple of things make me guardedly optimistic. Maybe I'm just hopefully naive. But more groups, like the woman from the back, I think disinterested public and patient groups, that is not funded by pharma and so on, but actually getting engaged in this stuff is good in itself, and I think they will start to have those conversations. I mean, citizens need to have conversations with each other that are not dominated by the supply side either, or by policy wonks like me either. I mean, they need to own these issues a little bit more. And I think there is a bit of a healthy skepticism about superabundance going on at the very beginning of that. But I think more broadly, and there are some researchers who are very interested in patient engagement and public engagement. As you suggest, it's really hard. It's hard to do well Nobody claims to do it well. It's really, really tough, even when people make a big effort. And then there's the other issue of how much do you want the public to spend its social capital and spare time thinking about healthcare? You know, they've got other things to think about. Public transit, education, where to have your next holiday, what's the matter with your backhand. I mean, those are good things for the public to preoccupy itself with. But I will say this, I think the biggest neglected aspect of this is that governments, governing boards, and managers, most of whom share some of this diagnosis. I mean, I'm not saying they share it all, but I think this is not an unknown conversation there. They have made no effort to socially market this to the public. They're pathetic communicators. So the communication is driven by the interest groups on the supply side, and they capture the public attention. So we know how successful, and I say this with all respect, pharma is magnificent at communicating its view of the world to the public. If you don't want that view of the world to be the exclusive one, or if you don't think that everything that the nurses union or the medical association or the PT association says is necessarily in the public interest, you have to have both another message and an effective and credible way to communicate it. So I think someone needs to take the lead in launching that conversation and conceiving of the problem as a competition for the public mind to broaden the public's perspective. I think it's doable, but you have to spend some money on it and you have to sustain it. I don't know if they will do that, but if they don't, then I think we're going to see more of the same, and I'm not very optimistic that we're going to make a lot of headway. And the last thing I would say about this is that while it's still in its infancy, good, clear, sophisticated, but intelligible public reporting about quality and safety and outcomes and repeating the message may have some impact over the longer haul. Again, we're very new at this in Canada, and the public doesn't know quite how to digest it, and the media aren't very good at it either. But again, over time, I think that will get better, and if it does get better, we may make some headway. And the very last thing I will say is don't waste a financial crisis. If we have to crank back the rate of growth in healthcare spending, maybe we'll get smarter about it. And maybe the public and the politicians and the media will be up for a conversation that we never are in times of abundance.
Well, I think that's a very challenging, strong note to end on. So thanks, Steve, and I'll ask you to join us again. Thanks, Steve.